Ms. Alcurie, in your testimony, you stated that Congress should conduct oversight to ensure that tribes and tribal organizations, specifically tribal epidemiology centers, have access to public health information at the same level as state and local health departments. Could you further expand on that and give examples of the barriers that exist for data sharing right now? Yes, to you.
I think, prior to becoming the chairwoman, I actually worked where Ms. Church works right now at the Great Plains Tribal Chairman's Health Board. I was the administrator for the Northern Plains Epidemiology Center at that time. And one of the things that and this is way back in 2010, we were asking for data sharing then from the state, and also, I know we're here 2023. We just went through a pandemic. We don't know if we're going to go through another one, and we're still asking that question, why are we not sharing data? And as a tribal chairwoman now, I can say this, it's not the only agency that we struggle with that. At the Bureau of Indian Affairs, it's the same thing. And I don't mean to throw that in there, but I mean, this is something that we need to get past. We cannot adequately address all our needs at the tribe, even as decision makers and these ladies here at the health boards, in addressing our healthcare needs without collecting the data and sharing the information so we can tell our story to you and you can tell the story adequately also. So the epidemiology, the data is so important. We just need to get past that.
Ms. Church, you seem to have some experience with this same problem.
Yes.
Yeah. Recently, I shared COVID, what happened during COVID-19. And not having that information made it so that we couldn't prioritize which of our 17 reservations that we were going to support for emergency operations. We operated a regional emergency operations center. And I believe because of that, people died unnecessarily. We could have done more if we were at the right place at the right time, and we didn't know where to be at the right place at the right time. Right now, with the syphilis outbreak, we reached out to CDC, we reached out to IHS for information. We reached out to CDC for an EpiAid. They're in the process now of responding to that request for an EpiAid, but I still don't know where to tell them to go first. And IHS has, I think, 10 days to respond with an answer. The acting area director in Aberdeen responded when I followed up on day 10 for information on the outbreak. His response was, we are still looking into the legality of sharing that information.
Okay, all right. I'd like to direct my next question to Laura Platero. Since Portland area has both tribally run and IHS-run health facilities, can you discuss some of the differences you've seen between management styles? And do you think facilities are learning from each other about what are best practices and how to ensure culturally competent health care for your tribal members?
Thank you, Chair Hageman. In terms of management styles, I would say that tribally operated facilities have more decision-making authority, and this results in more timely decisions. For example, they're able to purchase equipment supplies that they need without having to get approval at the area level. Similarly, staff training, they can make those decisions locally rather than have to go to the area to get approval for those. For hiring, it also can take months for a federal facility to get someone hired. By the time the person gets through the process, they may not be available. In terms of the tribal facilities, of course, they have that flexibility to expedite hiring when there is a need. There's also funding flexibilities for tribally operated facilities in terms of moving funding across sub-accounts So if someone would like to direct some healthcare funds to their behavioral health program or their mental health program, they can move those funds. Federal facilities are unable to do this. So there's just a lack of flexibility overall. And we've heard from some of our communities, even with presence in the community, many individuals who work at the federally operated facilities may not necessarily be integrated into the community or be part of social events. And I think it does matter to have a presence like at events locally in the community. And I'm sure that's not the case for all places, but I heard that from one tribe. Also, PRC eligibility for federally operated facilities. We've heard there are a lot of delays. There's penalties to members who get billed for services. This has been extremely burdensome. We heard of one incident where it resulted in someone not getting care and they ended up passing. So, and that tribe did, I'd rather not give their name, but I'm happy to share that later with the committee and connect you with the tribe. They did want to talk with you.
Okay, well, thank you for that. Why don't we go for a second round of questions? I have a couple of questions that I wanted to ask. Specifically to Ms. Church. You state in your statement, you mentioned the lack of staffing at Great Plains IHS facilities, and that you think improvements in recruiting and retention will not only improve care, but eventually be cost effective. Could you further expand on that and what recruitment and retention initiatives you have found to be useful and effective?
At what we believe at Oyate Health Center, I can speak from the tribal perspective, is that we have to grow our own. So we run a health facility, but we also run what I call a learning facility. We create opportunities within every area of Oyate Health Center to foster additional training for our current employees, and we want to become a learning center for programs, whether it is phlebotomy or our next goal is residency. If you're if you're fostering your own community and your own staff, they're more likely to stay. And the commitment is there, not because they have a IHS payback, but because they believe in the mission.
Okay, and I just wanted to ask Ms. Platero, in terms, Ms. Rosette, do all of the urban areas in the United States have Indian healthcare services that they provide?
There's some of them, I mean, there's, some provide alcohol treatment, and some of them provide referrals, but maybe not any medical care. There's, outreach and referral, there's limited ambulatory, and then there's full ambulatory. So there's 3 different types of services they can provide, and then so in some form, yes.
Okay, thank you.